The knee joint is a synovial joint of the hinge variety. It's a compound joint formed in part by an articulation between the patella and the anterior part of the distal end of the femur, the condyles of the femur. And most of the joint is it's an articulation between the distal end of the femur here, the condyles of the femur, and the condyles of the tibia, the superior surface of the condyles of the tibia, what we call the tibial plateaus. Being a hinge joint, it allows movement of flexion and extension, but in addition to that, it's a modified hinge joint, so it allows a little degree of medial and lateral rotation, and this is only allowed during flexion of the knee joint. Note that the fibula does not participate in the formation of the knee joint, and thus the fibula is not a weight-bearing bone. It only serves for muscle attachment, but the fibula participates in the formation of the ankle joint. This is a view of the distal end of the condyles of the femur, and you can see here that this is the articular surface for the tibia, and here is the articular surface for the patella. This is a view of the tibia, and you can see that the condyles of the tibia, they are flattened superiorly, and they form what we call the tibial plateaus. In between the tibial plateaus, there is an intercondylar area. Between the two condyles, there is an intercondylar area and intercondylar tubercles. The stability of the knee joint, like any other joint in the body, depends on three factors: bony factor, muscular factor, and ligamentous factor. The bony factor here is negligible because of the flatness of the condyles of the tibia, the tibial plateaus. It's only the intercondylar tubercles that are partly important for preventing side-to-side movement, but the main factor here in stabilizing the knee joint is the muscular factor, and the most important muscle here is the quadriceps femoris muscle. This is the tendon of quadriceps femoris muscle that is attached to the patella. The patella is a sesamoid bone in the tendon of the quadriceps femoris muscle, and the patella is attached to the tuberosity of the tibia by the ligamentum patelli. So this is the ligamentum patelli attaching to the tuberosity of the tibia. Here you can see the big muscle here in the front of the thigh, the quadriceps femoris. It is formed of vastus medialis, vastus lateralis, rectus femoris, and the vastus intermedius muscle, which is located a little bit deeper. This is the vastus intermedius muscle, and you can see that the three vasti, in addition to the rectus femoris, they form the tendon, the quadriceps femoris tendon that is attached to the patella. This muscle is very important for the stability of the knee joint, and atrophy of this muscle after long periods of rest, like when the lower limb is put in a plaster cast, will result in instability of the knee joint. Not only this muscle is important for the stability of the knee joint, but there are some other muscles like the tensor of the fascia lata muscle, this one, and the gluteus maximus muscle. Both of them are attached to the iliotibial tract that is attached to the tibia, and these two muscles with the iliotibial tract to which they are attached are important for the stability of an extended or semi-flexed knee joint. The third factor in the stability of the joint is ligaments, and here we have strong ligaments. Some of these ligaments are extracapsular ligaments, that's to say they are located outside the capsule, and in fact they are thickenings of the capsule of the knee joint. These are collateral ligaments, an example of them. Like any other hinge joint, there are collateral ligaments, thickenings on the side of the joint, and so we have a medial collateral ligament and a lateral collateral ligament. The lateral is also called the fibular collateral ligament because it's attached to the fibula, and the medial is called the tibial collateral ligament because it's attached to the tibia. There are other extracapsular or extrinsic ligaments. And these are the oblique popliteal ligament and the arcuate ligament, which we will discuss later on. The other ligaments are intracapsular ligaments, and the most important of these intracapsular ligaments are the cruciate ligaments. You can see them here inside the knee joint, the cruciate ligaments. I will talk about the cruciate ligaments in a moment. You can see that they form like the letter X. That's why they are called cruciate ligaments. They are located inside the capsule of the knee joint. This is a plastinated model of the knee joint. Again, you can see the tendon of the quadriceps muscle, the patella, which is sesamoid bone in this tendon, ligamentum patelli, which is attached to the tuberosity of the tibia. The lateral collateral ligament. Note that the lateral collateral ligament is cord-like. It's attached between the head of the fibula and the lateral epicondyle of the femur. The medial collateral ligament, if you compare it with the lateral, the tibial collateral ligament, you can see that it is wider. It's attached to the medial epicondyle of the femur from one side, and it's attached to the medial condyle of the tibia and the upper part of the medial surface of the tibia as well. It's wider than the cord-like lateral or fibular collateral ligament. Also, I want you to note that the lateral collateral ligament is away from this meniscus, the lateral meniscus. I will talk about the menisci in a moment, and the lateral collateral ligament is away. In between them, there is a tendon of muscle which is called Popliteus muscle. But on the medial side, the medial collateral ligament is in fact attached to the medial meniscus. It's attached to it, unlike the lateral collateral ligament. Inside the capsule of the knee joint, in addition to the menisci that I've just mentioned, you can see the cruciate ligaments. So this is an example of a cruciate ligament. This is a posterior cruciate ligament. The cruciate ligaments are anterior and posterior cruciate ligaments, and they are named according to their attachment to the intercondylar area of the tibia. So this is again the intercondylar area of the tibia between the two tibial plateaus. And so the posterior cruciate ligament is attached to the posterior aspect of the intercondylar area. That's why it's called the posterior cruciate, while the anterior cruciate ligament is attached to the anterior intercondylar area of the tibia, and that's why it's called the anterior cruciate ligaments. So this is to show you here the anterior cruciate ligament. This is the anterior cruciate ligament. It's attached to the anterior intercondylar area of the tibia on one side, and the other side, superiorly or proximally, it's attached to the lateral condyle of the femur. As you can see, the direction of fibers of this ligament from the anterior intercondylar area of the tibia to the lateral condyle of the femur, while the posterior cruciate ligament here is attached to the posterior intercondylar area of the tibia, and proximally it is attached to the medial, this is the medial condyle of the femur. In addition to the anterior and posterior cruciate ligaments, which are located inside the capsule of the knee joint, there is another ligament here, and this is called meniscofemoral ligament because it's attached or connects between the lateral meniscus, this is the lateral meniscus, and the femur. So it's a meniscofemoral ligament. Now this point here is important to consider. It's about the dimensions and the shape of the articular surfaces at the distal end of the femur. If you look at the medial side, medial condyle, this is the medial condyle of the femur, you can see that the distal end of the medial condyle that articulates with the tibia is almost oval, and it has a longer anteroposterior diameter than the lateral condyle, than the articular surface of the lateral condyle. So this is the articular surface of the lateral condyle, the tibial articular surface. That's to say, the surface that articulates with the tibia. It's more or less circular, and as you can see that it is shorter anteroposteriorly than that on the lateral side. Don't look at the prominence here. This prominence, or this area of the femur, it does not articulate with the tibia, it articulates with the patella. And you can see that it's more prominent anteriorly on the lateral side than on the medial side. This is for the stability of the patella, because the patella tends to dislocate laterally, and the prominence of this lateral surface anteriorly will hold the patella and prevent its lateral dislocation. But here in the knee joint, we are concerned with the articulation with the tibia, and these are the articular surfaces with the tibia. On the lateral side, on the lateral condyle, it is more or less circular, and on the medial condyle, it's more or less oval with a longer anteroposterior diameter. So during extension of the knee, the lateral articular surface with the tibia on the lateral condyle of the femur will come to an end, but there is more surface on the medial side during extension. And so at the end of extension, there will be medial rotation, because this is the only surface that can move. There will be medial rotation of the femur on the tibia, resulting in tightening of the ligament and locking of the knee joint at extension, which makes the knee more stable. This means that the knee joint, prior to flexion, it needs to laterally rotate. And this lateral rotation of the knee joint at the beginning of flexion is called the unlocking of the knee, and is performed by the popliteus muscle. The difference in the articular surfaces on the distal end of the femur also imprints on itself on the articular surfaces of the tibia. You can see that on the medial side, the articular surface here is more or less oval if you compare it with the circular articular surface on the proximal end, or the upper end of the tibial plateau. And it also reflects itself on the shape of the menisci, the semilunar cartilages, as we will see in a moment. These are the menisci, the medial meniscus and the lateral meniscus. They are made of fibrocartilage, and each one has two horns, anterior and posterior horns, that are attached to the intercondylar area of the tibia. Note that the menisci, from one side, they are flat, and they are attached to the tibial plateaus, and that the rim of the meniscus is thick, it's wedge-shaped. And so the meniscus looks concave superiorly, and this is to make the articular surface of the tibia more adaptable to the articular surface of the femur. The other thing I want you to note is the shape of these cartilages. Yes, they are crescentic in shape, they are semilunar, but the medial one is C-shaped and longer anteroposteriorly than the lateral one. And this is in conformity with the articular surfaces on the femur, as I have just mentioned. The medial articular surface of the femur is oval, longer anteroposteriorly, so this cartilage, this semilunar cartilage, this intra-articular disc, is elongated anteroposteriorly, while this one is more or less circular in conformity with the circular articular surface on the distal end of the lateral condyle of the femur. The function of these menisci is that they act as shock absorbers, as you might expect. The other thing, that they adapt the articular surface of the tibia to that of the femur. Not only they make them more concave, because they are flat, so not only they make them more concave to adapt them to the articular surface of the femur, but in fact, I want you to notice that the distal end of the femur here, you can see that the distal end of the femur is described as cam-shaped. The convexity on the distal end, the curvature on the distal end of the femur, is less than the curvature on the posterior part of the distal end. So this means that there is changing curvature during flexion and extension of the knee joint, then there is changing curvature of the articular surface of the femur on the tibia. I'll show it to you again here. You can see that now the knee joint is extended, and it is the distal end that is articulating. It is less curved than during flexion. For example, here, now we have a more curved articular surface of the femur articulating with the tibia. So during this movement of flexion and extension, you can expect that these menisci, that they open and close, and so that to adapt the articular surface to that of the femur, to the changing curvature of the articular surface of the femur. While they are doing so, opening and closing, they're going to distribute the synovial fluid inside this big synovial joint. The medial collateral ligament, the tibial collateral ligament, is weaker than the lateral collateral ligament. The medial collateral ligament, as you can see, is attached to the medial meniscus. It's not separated from it like the lateral collateral ligament separated from the lateral meniscus. And so what happens in injuries of the knee joint, many of these injuries take place when the knee joint is hit from the lateral side. If it is hit on the lateral side and the person is standing, then the tibia and fibula are tight on the floor. And so what will happen is that the femur will become abducted on the tibia, like this. If the hit comes from the lateral side, it will cause abduction of the femur on the tibia. And as you can see here, this will cause tension in the medial collateral ligament because it's weaker than the lateral collateral ligament. It tends to rupture, to be injured. And while it is injured, it might cause injury of the medial meniscus as well, because the medial meniscus is attached to the medial collateral ligament. This injury in many cases is also associated with injury of the anterior cruciate ligament, which is the weaker of the cruciate ligament. This is to show you a dissected knee joint. You can see the knee joint is open. This is the lateral condyle and medial condyle of the femur. And note the articular surface with the tibia here. On the lateral side it's circular, on the medial side is elongated oval anteroposteriorly. Inside the knee joint where the capsule has been opened, you can see the menisci. This is the lateral meniscus with its anterior horn, the medial meniscus here with the anterior horn, and the two anterior horns are attached by a transverse ligament, which is another intracapsular ligament here. Also, you can see the cruciate ligaments, the anterior cruciate ligament, and that's attached to the anterior intercondylar area on one side and the lateral condyle of the femur on the other side. And here you can see the posterior cruciate ligament attached anteriorly and superiorly to the medial condyle of the femur. Here you can see the thickening in the capsule of the knee joint that forms the medial collateral ligament or tibial collateral ligament. While on the lateral side, you can see the cord-like fibular collateral ligament. And note that the fibular collateral ligament is much away from the lateral meniscus. And in between them, in fact, there is a tendon. This is the tendon of popliteus muscle, separating between the lateral collateral ligament and the lateral meniscus. The tendon of popliteus is attached to the lateral condyle of the femur, while the lateral collateral ligament is attached to the lateral epicondyle of the femur. This is a posterior view of the knee joint. We can see here, this is the popliteus muscle, the fleshy part of the popliteus muscle. It's attached to the tibia, posterior aspect of the tibia above the soleal line. And here is the tendon of popliteus. It goes into the capsule of the knee joint, and there is a thickening here in the capsule where the tendon of popliteus goes inside the capsule, which is called the arcuate ligament. It's another extracapsular ligament of the knee joint. And also you can notice here that there is a thickening, this shiny thickening on the posterior aspect of the capsule of the knee joint. It's called the oblique popliteal ligament. In fact, the oblique popliteal ligament is an extension of the tendon of semimembranosus muscle. This is the semimembranosus muscle, one of the muscles of the hamstring compartment. This is semitendinosus, but this is the semimembranosus muscle, which is attached to the posterior aspect of the medial condyle of the tibia. It sends expansions. One of these expansions goes behind the knee joint, upwards and to the lateral side, and it's called the oblique popliteal ligament. It's important for strengthening the knee joint posteriorly, and it is one of the extracapsular ligaments of the knee joint.
This is an X-ray of the knee joint, a lateral view, showing the femur, the distal end of the femur. Note the cam-shaped articular surface with the tibia. You can see here the difference in the curvature at the posterior end and at the distal end of the condyles of the femur. Of course, here the medial and lateral condyles of the femur are overlapping. This is a lateral view. Anteriorly, there is an articulation with the patella, and here you can see the tibia, the tibial plateaus, and this is the head of the fibula and the shaft of the fibula. Here there is the tuberosity of the tibia. These two bones are not always seen. They are sesamoid bones in the medial and lateral head of gastrocnemius muscle. They are called the fabella. Here you can see the intercondylar eminence, the shadow of the intercondylar eminence, and this is the shadow of the adductor tubercle of the femur. This is an anteroposterior view of the knee joint. You can see the distal end of the femur. These are the condyles of the femur. And this is the overlapping shadow of the patella. You can see that the patella has a base, and the apex of the patella is located inferiorly. The apex of the patella is level with the joint space. So this is the joint space here. We call it joint space, but in fact it is not a space, but it is occupied by the cartilages, at the articular cartilages at the distal end of the femur or at the tibial plateaus, and in between them are the semilunar cartilages. You can see the tibial plateaus, the intercondylar eminence, and here this is the head of the fibula with the styloid process, the head and the neck, and here is the shaft of the fibula.